using Zoom drop-in sessions. He's had a couple so far with great discussions with providers, the hope being if they're comfortable with using a CGM and understanding the results, they'll be more likely to be able to help their patients. Dexcom G6, on the other hand, has a slightly different process. We forwarded the list of folks who said they were interested in receiving a sample to Dexcom. So they should be contacting Jackie, the PO, or the clinicians themselves to coordinate.
I'll contact the clinicians themselves, I believe.
And so if you hear from someone that they didn't check their email or didn't get a contact, please do let us know. We do have a form and we'll send you this link in slides if you've not completed for Dexcom. Not too late to do it. We just ask that people are at a participating practice, and that could be a physician, PNP, or clinical pharmacist, and the Dexcom sales rep will contact them directly. I've done this myself. I found it incredibly useful just to understand how the CGM is placed, to look at the data evaluation worksheet, understand how the data comes back and how to share it with the practice. So here are our additional optional Dexcom training sessions. Lots and lots of wonderful resources, information that we're sharing with you. Please share these with your clinicians if there's someone specific in the practice. Pharmacist or someone else who's going to particularly take responsibility for training or teaching about CGM, this may be up their alley. The next thing I want to share with you is some of our resources. And so I'm going to try to go from here to our website and to show you where all of these live. But based on your request, we've started developing and publishing resources for us to use with patients on the MCT2D website. So the first one we're going to show you is a daily tracker. This is a tracking log that includes some basic instructions for patient on use, the opportunity for them to set their own health goals, a carbohydrate goal, etc., and has some recommended resources for them to learn more. And then there are diet tracking pages that have space to add their blood sugar before they ate, the food or drink item that they had, and carbohydrate count if they wish to count, and then their blood sugar after the meal, either 1 hour or 2 hours. They're able to then log their total carbs for the day if they're tracking that with their clinician or pharmacist to understand that very low, somewhat low, moderate, or high carbohydrate diet plan that they've been advised to have, as well as physical activity. And then what I think my patients find really useful about this is the reflection piece. How was my energy? How were my food cravings? Reflecting on that, was I hungry? Was I not when I ate? That they find really helpful in making behavior change. So if I press click here, that's probably not visible. I'm going to do stop share and then reshare.
Yep, just make sure you share your entire screen and not just a specific window.
That is a good idea. I feel like it's going to, can you see everybody's faces on this as well, Jackie?
Nope, just the tracker and your PowerPoint in the background. Yep.
Excellent. So when you go to our website, you'll go to mct2d.org. If you started at the main website, then you'd go to resources and resource library, and you'd be able to browse to the individual resource. And so here is the MCT2D daily meal and blood sugar tracker with carb cheat sheet. This is one of the resources we have available for you. And so those instructions, how the tracker is going to be helpful for you, that you'll discuss your goals with your healthcare provider, you'll write down your number of carbs, you'll continue tracking, an explanation of basic terms, your health goals. I love this page, both thanks to our graphic designer, Laria and Noah. It looks so beautiful, but because it's really helpful information about foods that are generally 0 carb, 1 or 2 grams of carbs, 3 or 4, 5 to 10, and 10 to 20, and then foods that might be higher in carbohydrates. We spend a lot of time talking to patients about how many grams of carbs are in 1 bowl of rice or 1 cup of rice. And then websites, Diet Doctor, Ditch the Carbs, 2 books that are easy to find for patients, one that's free on the internet, and then 2 apps that they might want to use. And then that goes to the next page, to the sheets that they're going to use throughout their tracking. And so 1 sheet for each page, and when they download or print this, it's going to be 9 pages long, so that they're getting a different option for each day. And they can do this for self-tracking. They can bring it back to their visit, scan it into your EMR, bring it back to the dietitian, whatever your clinicians think is most helpful. So I am going to go back behind that, great, to the tracking log and keep showing you resources. Please stop, add in the chat, raise a hand if you have anything to say or comments. Otherwise, we'll save lots and lots of time at the end. Second resource, did I miss anything? Second resource, Senior Savings Program. This, again, is going to be helpful more so at the end of the year. As we discussed in a couple of our training modules, Medicare Part D has a new plan for drug plans called the Senior Savings Program that drastically reduces the cost of insulins, making more money available for other resources, for other medications. And so this is only available to people when they're enrolling. Might be helpful for people who are new to Medicare who are enrolling in the middle of the year, but will definitely be helpful at the end of the year in October, November, December when people are enrolling in a new plan. And this just explains to them how that model is going to be really helpful for them in affording their insulin. Next resource, coverage guide. So this is on the website here, and I'm going to open it up as a PDF if our link is working. No, this is one of the links that I feel like was not working perfectly, but it's going
Let me email it to you really quick, Dr. Ashman.
Go through each of the pages here one by one. So I'll wait for that email to come through, but essentially there's two guides here. One is for SGLT2s, backside GLP-1 receptor agonists, and then there's a separate one just looking at CGM coverage. I'm going to see, you're all going to see my email and my very, very messy home screen. So I'm going to stop sharing.
Noah, can you actually send that? I think that you have the most recent copy.
I'm looking for it now. Hold on. Sorry.
That's okay. No worries, because I'll just show the resource that is available on the website. So thank you, the person who said this is fantastic. I think, Jackie, is our understanding that this is still up to date for 2022?
Yes, I looked right at the end of last year. Most insurers had their 2022 guides out, so we were able to make changes to them where we could. The one caveat with this that's been a little bit of a challenge is there may be plans that have carve outs. So Blue Cross Blue Shield, a patient may look like they have Blue Cross Blue Shield insurance. That's what you have on record for them. But if they have a pharmacy carve out and they get their pharmacy through Magellan or Express Scripts or something else, it's not going to be identical to what this chart says. So we're trying to make a kind of complementary guide to this that tells you how to determine if a patient has a carve out and what that's going to look like, and around the percentage of members that have carve outs at each insurance plan, so that you can just have a little bit more information there. So it's definitely general and is not going to apply to every specific situation just because of issues like that. But this still should be helpful around understanding the requirements, especially on the CGM side, which isn't always clear, and just knowing in general what's like most likely to be covered. And Dr. Ashman, that's linked in the chat now. So if you open it there, you should be able to see the full guide.
Fixing the button. Thanks. This is also our chance to fix everything. Can you see that as well, Jackie?
Yeah.
Okay, great. So I'm going to just kind of do a demo of all of the sections. So as you're explaining this to clinical champions, if they have any questions, it all makes sense to you. You can tell us if it makes sense to you. So a blue star is that it's covered. Red X is not covered. Step therapy required. And then prior authorization or other coverage issues. Every insurance plan here, private versus public. And then recommended is really the medications that have the most proven benefit for reducing cardiovascular, renal, and metabolic outcomes versus ones that have like a little bit less evidence behind them. And then, as we've been doing in our trainings, kind of just leading people to appreciate, at this point, Jardiance or empagliflozin is covered by most of the plans. Here's our disclaimer that it really may not be the same for those that have pharmacy carve-outs, and then some definitions for step therapy and coverage limits. So then when you go to GLPs, same idea, same information. Step therapy, there is one agent here that comes as an injection and then a pill. And so there's one plan that does not cover the pill, but it does cover the injection. So just some specifics and kind of our preferred medications that really have the most evidence behind them versus ones that might be covered. This is going to change every year. Even since we published this, there's one new study changing some of this data. And so we will update it on a rolling basis, especially when we get new information about insurance companies with changes in their formulary. And then moving on to CGM, differences here between private plans and public plans, and looking at how the clinicians should be doing the ordering here. So looking at Blue Cross, for example, it's a covered benefit only through the pharmacy, versus if done through DME, there are multiple coverage criteria. For HAP, looking at patients who are able to be prescribed in their criteria, the daily insulin injections and monitoring, and A1C above goal with recurrent severe hypoglycemia. Medicare just changed this year, but now we are able to get CGMs covered for patients with 3 or more daily insulin injections, needing adjustment, etc. Medicaid still not covered from an advocacy perspective. It's something that we're continuing to work on. So questions in the chat about that particular tool?
Yeah, and like Dr. Ashman mentioned, we are both talking with Medicaid, we're talking with HAP, we're talking about United, about some other coverage specifically related to the CGMs and how we can kind of adapt that. And they're definitely all considering some kind of different levels. So we'll keep everyone updated about any progress we're able to make in that space.
We for sure know that it is more complicated than just one page, but trying to get it on one page for you. We heard from the physicians that it was difficult for them to understand which agent is appropriate to prevent which complication. And this is all in ADA guidelines, which just changed. So this particular tool, while it is on the website, we're going to be making some changes, and we will send you an email when we've updated it with the 2022 information, but giving you specific information about which of the agents has an FDA label indication, for example, for heart failure, versus there's a study supporting it and it doesn't have the FDA label. So they will use this in their clinical encounters with patients, and then use the insurance piece to decide between those two things, clinical considerations and insurance considerations, what choice they want to make. And then dosing guidelines. This is really just to ensure that the concern about safe prescribing and making sure that physicians and clinicians understand complications and risks, that they are using the appropriate dose for patients with kidney disease, and dose adjusting properly. So some more updates with 2022 guidelines, and then this will be on our website as well. So I'm going to toggle over to the resource library now, and then just show you, we've got a search term up at the top. And so if I type in CGM, it's going to show me resources that we've tagged as CGM resources. If I type in insurance, it's going to flag all of the ones that we've flagged essentially with a search term for insurance. The way that I've used the resource library so far is to look by initiative. So if I'm looking for my CGM resources, I'm browsing by initiative. I'm finding my medications and CGM coverage guide. And then we have a lot of the resources that we've kind of culled for you, both from the literature. Doctors have asked, what's the evidence behind this? And then all of our video resources that I'll show you in a little different organization in a second. So that's by initiative, diet and nutrition. The first thing on there is the meal and blood sugar tracker with a carb cheat sheet, a link to a book on carb counting, and then links to some other resources. Here is low carb for any budget. If you haven't seen this before, this is an online ebook, no cost for patients, and really, really meant for people on a budget for carb counting. And then finally, jumping to medication resources, this will end up being a lot of those different tools that are clinician focused for medications. Newest stuff is going to be at the top. So we've got our resources for clinical care, organized similarly, point of care resources for the clinicians, and then resources for patient and family. Some of these are going to be the same, but also organized in that different fashion. And then we've got our featured CGM videos. And so patients who need education about their particular CGM monitor. The resources from Dexcom and Abbott are great. We're not going to reinvent the wheel, and those are available through our website as well. And then if you continue to scroll down, everything that we've tagged as diet and nutrition is here, clinician resources, patient-friendly resources, etc. So it's a work in progress, but the resources that we have placed so far are the ones that we were told are highest yield and most important. So hopefully people will find those helpful. I'm going to just move on to our last talking point, and then we can take time for questions. And Jackie, maybe I can turn it over to you for this one.
Yeah, absolutely. And when we wrap up with our content for the day, we definitely want to hear about any other resource ideas that you have or want. We're also working on specific like patient savings programs resources for the different drug manufacturers. So how you would use the Lilly Cares and get a patient on a program there, Novo Nordisk's program, et cetera, so that that can be a resource for providers as well. But we also want to hear about the things that you want and need, because that's how we're getting all these recommendations from the POs, the providers, what you want to see that will help you implement these things. Okay, so regarding this, the letter to share PPQC and CCDA data. So as everyone knows, from like the start of this program, we've always wanted to build out this all patient, all payer data registry that covers basically everyone we can in the state. Right now, we only have Blue Cross and Blue Cross MA data within the database because that's what we had like permission from for Blue Cross. And so in order to expand that a little bit, including all the data that's most of the data that the registry is based on right now is PPQC data. There's some claims data. So by signing this letter, we would be able to add all payer PPQC data to the registry soon, which would be great. We eventually want to incorporate CCDAs, so that letter encompasses those as well, so that we're ready for that future state. That was sent out to everyone, all the PO primary contacts, including the admin leads and the clinical champions, last Monday. We would like to get those letters as soon as possible. Letter end of January is kind of our last due date. And one major caveat is please make sure that the person who signs this is the same person who signed your participation agreement. Mayan asked to look at who all the signatories would be and signed off on those signatories, and any that we've gotten yet that weren't signed by that person, they've had us circle back with. So just make sure that you're having the person who signed your participation agreement sign these. And if you have any questions at all, let me know. And the sooner that we can get all these letters in and signed, the sooner we can start kind of expanding our database. So thanks, everyone.
All right, upcoming events and deliverables. We're de-inviting all of you to an in-person meeting later this week. We didn't figure you wanted to meet with us. And so we are very, very hopeful that we'll be able to have in-person meetings at some point, but until then, appreciate your patience with Zoom. We are giving you through the 14th of January to submit any requested changes to region allocation. We'll review and finalize those so that we can start to have some more small group opportunities to do learning from our peers, et cetera. The on-demand training, all of the CME options that the clinical champions participated in are being processed currently. We hope to have them available by the end of the week. We will share the Beaumont Health System CME website with you, and that will be the website that other people can use to go through and get CME credit for those same presentations. Excited about the version 2 of the MCT2D dashboard. Important things that we're adding, we'll be adding blood pressure data, and then pick lists for additional diabetes medications. So you can identify someone who's on, for example, a sulfonylurea who you might want to switch to a different medication. And hopefully we will launch that by early March. Anything else, Jackie, on that?
Nope, I think that's good. So when we send you an email about all of the training information, we'll include the link to the portal. We're going to update those every 2 weeks. Beaumont's going to communicate with us who's completed the training. So we should be able to show you not as frequently as updated as when we were hosting it, but still be able to show you all of the attendance at some kind of regular basis. And we'll also be sending out with that email like an optional training needs assessment, like we'd mentioned at one of these previous meetings. So if you have, if you want to require any sort of training at your practices, this helps you determine who might need it and who might benefit from it. I can actually show really quick just what that looks like if I steal sharing from you for a second, Dr. Ashman. So, like I said, this is completely optional for you to distribute more broadly at your practices than to just the clinical champions if you'd like, but it's going to ask questions about how they view this SGLT2s, if they have, if they understand them. Same with the medication or the GLP-1s, asking questions about their experience and expertise around the CGMs, and then finally the low carb diet. So if you wanted to, and we're interested in doing training more extensively at the practices, you could kind of get individualized recommendations for each person there. So there may be a provider who's really strong in these medications and understands them, but may benefit from taking the CGM training. So you can use that completely optionally to try to guide additional education and training for your providers as you feel is needed. And I see
the best way for us to, once providers take that test, to get the information back to the PO.
What's that? Oh, so it'll be like we'll have the same homepage that you use to view like your other dashboard tracking, things like that. We're going to make a page that the responses are immediately filtered to based off of PO. So you'll be able to at any time kind of see the most up-to-date info there as far as what that looks like. And I got a question in the chat about the case summaries that I think was specifically to me that just so I want to make sure everyone else sees it and can benefit from this. So the question was about the required case summaries that we're asking for the collaborative. So let me show that really quickly as well. And these are linked on our dashboards that you have under like, the VBR dashboards. And what it will look like is this. So when a provider opens this, and we'll share the link, and we'll also put a link on our MCT2D.com website as well so that they can access it from there. So it'll be the name of the person completing this form, because it could be a care manager or a nurse working in that office. It doesn't necessarily need to be the PCP that's earning VBR. We're linking it to them with this column right here to determine that. But if someone else has done a lot of work with this, we'd link it in here. Then we ask what intervention the patient received, so they can select multiple. If they did more than one, they can just select one. Asking what barriers this patient was facing related to their type 2 diabetes care, what went well with the intervention, did the intervention achieve the outcomes you'd hope for? So this isn't something that can be completed at the exact moment of prescribing. You need to have like a little bit of distance on that to see how it worked out for the patient. What challenges did you experience in providing this intervention? So we'd want to know about anything here. So had a difficult time like finding what drug was covered, a patient didn't want to use an injectable medication, they didn't understand the diet, whatever that may be there, so that we could try to help and respond to that. And then a few things just getting at like what was used and what was needed. So as always, we're looking to try to understand how we can better help you. So what resources do you wish you had that would have made this intervention easier next time? And which resources helped you that you could share with others in the collaborative? So maybe someone has a workflow that's been really helpful for them that they're willing to share. We also give them the option to attach that as well. So pretty high level, just really looking at what went well, what was challenging, what they had and what they needed, so that we can kind of better respond to and help others in the collaborative with these types of things as well. So there's 3 of these due by every VBR earning provider in the collaborative throughout like the entire collaborative. So I'm thinking we're going to have our first one be due at the end of March, because that would be prior to these regional meetings that were hosted. And I'll send out an email officially saying that, and with the link to it as well. And we'll make sure we get that link posted really clearly on the website too, so that you can access it from there. So it's really easy to find and link back to. And then there's just 2 others due at some point during the remainder of the year. I don't think will be as prescriptive as when those ones are due, but the VBR year is through the end of September. So it would be 1 before 3/31, and then the other 2 just really at any point from 3/31 to the end of the VBR year. Thanks. I'll hand it back over to you, Dr. Ashman.
Yeah, so that's all we had to share with you. We've got plenty of time for questions, comments. Would really love to hear your feedback about what's going well and what challenges you've experienced and how we can help that specifically with the resources we're developing.
If you have any questions about anything related to the collaborative, feel free to ask them now as well. It doesn't need to be specific to the resources. Yep, thanks, Ashley. And as always, when you hear from your providers, if there's needs, if you hear about them, just let us know, have them reach out to us. We're happy to respond to everything that people need and try to make things a little bit easier in that sense.
Well, we will stay on with you. You'll hear my Chihuahua barking in the background. And please, if you have any questions, just go ahead and unmute. And otherwise, Jackie will say goodbye until next month.
Yep, sounds good. I just want to say, Dr. Manzabar, I wanted to let you know last time we met, you asked about like a resource that you can use as kind of advocacy around the CGMs and the medications with insurers that has like kind of common language and resources. I'm about 50% done with that. Working on the other half of it, and we'll have that for you by the next one of these PO monthly touch points at the latest. And then John had suggested in the chat, suggesting a resource guide that fits to varying cultural food decisions so that others can be guided correctly for low carb options that fit. Yes, we definitely want to create a lot of resources that are more culturally sensitive around like diet recommendations and recipes. And our dietitian position that we talked about at the last one of these monthly touch points was just posted today. So we're really hoping to find someone to fill that role who can help with a lot of building out these different types of recipes and different types of things so that it's a little bit more inclusive than the kind of traditional low carb diet advice. And yes, we would love your input. So we will reach out, John.
I think part of this being a collaborative is utilizing the resources and talents of everyone who's on the ground doing this work and not duplicating resources. Mm-hmm. The ADA has some really nice plate planning resources that are culturally specific as well. There's a lot of different things we can link to.
Okay, thanks, Erica. That's a great idea too. Posting some of the resources that we'd shared with Erica, Dr. Ashman, you helped write some of that response about the newer data suggesting a reversal of type 2 diabetes. So maybe we can pull together like a quick one pager with some of those sources. Great. Okay, well, as always, we are available by email anytime, so please feel free to reach out to me. I'll make sure that your questions and input get to the right person. And thank you everyone so much for your time this morning. We really appreciate it.
Thank you very much.
Jacqueline, I have a question. Oh, wait a minute, you're answering it.
Yeah, here, yeah, it might be easier to answer just like this. To ask the timeline for this to be started throughout our organization. So generally, we're hoping for everyone to start working on the QI, the CGMs, medications, prescribing of them, and the low carb diet, essentially like in January of this year. That said, we haven't really given like specific guidance around like what our first performance measure will be. So I know it's a little bit difficult to like try to be working towards that without having something specific in mind. And that's something we've been trying to figure out and work towards. And we've been thinking a lot on our end of what that's going to look like. In the meantime, I think it's good to just have people begin to think about what a process might look like if you're going to use care management to kind of get some of these things happening, like how you may want to structure it in that meantime, because they are all going to relate back to these QI. So I think just conceptualizing it for the meantime, meeting kind of the participation requirements that we've set out, including like the regional meetings that are coming up. And then we should have like more specific goals later within the year that I think will help to kind of drive that focus, if that helps at all.
Yes, thanks.
Thank you. Great. Thanks, everyone. Have a great afternoon.